Hello, everybody. My name is Amit Jain. I'm an orthopedic spine surgeon at Johns Hopkins. I take care of kids and adults with spinal problems, and my area of expertise is scoliosis surgery. Today, I'm going to be talking about a topic that's near and dear to my heart: adolescent idiopathic scoliosis. So, what is scoliosis? Well, scoliosis is a curvature of the spine, and it comes into several categories. There's the pediatric kind and the adult kind. So first, on the pediatric kind, it can be broken down by etiology. So there is idiopathic scoliosis, which is the most common type, and it can be broken down by age groups: infantile, which is 0 to 3, which is typically in babies; juvenile and young kids; and adolescent, which is typically in teenagers, so ages 10 to 19 or so. On the adult kind, there is idiopathic and de novo, which has more to do with degeneration of the discs. Some kids have scoliosis that doesn't quite fall into the idiopathic category. It may be because they have a genetic condition, they have a medical condition that leads to scoliosis, and we kind of bucket that into the neuromuscular syndromic or congenital categories. So scoliosis is a three-dimensional deformity of the spine. There's a lot of curvature of the spine that takes place, and unfortunately the curvature tends to be progressive. So in the coronal plane, which is this kind of front plane, there's a lateral deformity of the spine. So in other words, you see a curvature of the spine that's quite visible. In the sagittal plane, which is a little more subtle, that's the front-back plane, there's a loss of thoracic kyphosis, and there is actually lordosis. In other words, there is a dimple, or there is kind of a sway back in the middle of the thoracic spine, which is a little unusual. So the kid, instead of having the normal curvature of the roundedness of their back, actually has a little bit of a sink in there. And then on the axial plane, it's vertebral rotation. And the way you often perceive that is when you have the child bent forward, you see that the shoulders are uneven, you see that the shoulder blade is hiking up, or one side is kind of rotating, the rib is sticking out. Well, that's the axial plane deformity. So what are the signs you can look for? Well, oftentimes the head is off the center, the shoulders are uneven, there's a shift in the rib cage. A lot of families notice this first when they go on a beach trip and they may see the kid in a swimsuit, or they see the child at a pediatrician office for an annual well-child check. Well, those are some of the areas where this could be noticed. And furthermore, they can be pelvic imbalance, so that means one of the hips can be higher than the other, and that can again clue you into the fact that the child may have scoliosis and may need to be checked out. What's the problem with scoliosis? Well, unfortunately, in a younger patient, scoliosis can progress. And typically it can progress with both the growth spurt as well as a function of their age. So here's an example. This is a 12-year-old kid with about a 50-degree curve, which already is in a surgical range. And despite of recommending for medical treatment, the family opted for observation and unfortunately did progress. And as you can see, 6 months later, it progressed now to severe scoliosis, which is now about 65 degrees. And unfortunately continued to progress again, now almost a year later, to quite a massive curve. So that's a big problem. And here's a good illustration of what happens when you don't quite treat the problem. So we are usually pretty proactive about this and try to get this taken care of right away. At Johns Hopkins, we have a wonderful team of people: physicians, nurses, anesthesiologists, neuromonitoring technicians, and other experts who collaborate together to take care of scoliosis patients. We do several hundred of these surgeries a year, and we're really proud of our team. And we have together created a number of innovative things that really contribute to our successes. So the first thing that we have really focused a lot on is enhanced recovery pathways with specific protocols for scoliosis patients. These protocols have allowed us to do these surgeries with lower blood loss, lower hospital stay, faster recovery. So we are able to kind of put patients on certain medicines, use certain techniques in the OR with anesthesia, etc., that really enable patients to be up and about earlier and enhance their recovery and get them home sooner. Furthermore, we are now able to do selective thoracic fusion for a number of cases where we historically had to do a longer surgery with lumbar autocorrection due to better developments of techniques or better innovative kind of instrumentation that we are able to utilize. And in select cases, we were able to actually do fusion-less scoliosis surgery, which is really impressive because that basically allows the child to have their full range of motion without really disrupting their life. So here's an example. This is a 14-year-old kid with a very severe curve. You can see almost a 100-degree curve, very severe scoliosis. This is a boy. In the front plane, you can see that. In the side plane, you can see that. And you can see how there's a big slump in the thoracic spine. And that's, again, going back to the different deformity planes. This kid has all three planes being involved. And with surgery, this kid was able to get back to doing what they love, get out of the hospital within 3 days after surgery. Now, this is the type of surgery where the kid may have stayed in the hospital for a week or 2 weeks, but now able to get back much faster to what they like to do after surgery, thanks to some of those innovations I spoke about. Here is another example. This is a 15-year-old child with over a 100-degree curve, very severe curve. Unfortunately, very tough problem to tackle. We were able to do the surgery in a way where the child did not end up needing a blood transfusion, which is pretty cool. She just got her own blood back. We are able to correct the spine beautifully, restore her normal alignment, both in the frontal and the sagittal plane, and you can really see the remarkable improvement on her health and her long-term outcomes. Similarly, here is another 19-year-old boy with severe scoliosis, in this case affecting both the thoracic and the lumbar spine, so both the mid and the lower back. We did end up treating both of those. As a result, you can see the beautiful correction, the beautiful improvement in their overall scoliosis, and how now they have a normal spine that they can essentially have for their lifetime. And then here's a 13-year-old. This patient is a very high-level cheerleader. She had won some national and state championships and was really interested in continuing her cheerleading journey and competing at a national level. This kid was quite tricky because you can see both the thoracic and the lumbar curves are quite severe. Typically, this would necessitate going to the lower lumbar spine, but I was really interested in saving her levels, so I actually stopped at L3. And the reason I did that, which is kind of the midpoint of the low back, and the reason I did that is because I wanted to maintain her lumbar motion as much as possible so she can continue to being a super athlete that she is. And here's an example, and you won't believe this. This is 2 months after her surgery, where she's able to go back to her activities and able to do this kind of very advanced aerobic kind of maneuvers that otherwise literally would not be possible. Here is another example. This is a 13-year-old kid with severe thoracic and lumbar curve. But in this child, luckily the lumbar curve was somewhat flexible. She had some growth remaining. So I decided to leverage some of our newer technologies and really only focus on the thoracic spine to correct the mid-back. And I was hoping that the lower back would straighten itself out. By uncoiling the mid-back, the lower back will actually get better. And that's exactly what happened. And as you can see here, the low back normalized itself without us having to do surgery on it because we were able to fix the mid-back, which was pretty cool. So now she can have a lifetime of good health and full flexibility. Here's another example of a kid. Now this kid has a slightly different curve pattern. You can see that the curve is in the lumbar spine, so lower back. So this is a different story because now the lumbar spine has to be corrected and treated because that's the main problem. But you don't necessarily need to touch the mid-back. And that's what I did. I ended up doing a selective lumbar fusion in this case. And as you can see, this kid had an excellent restoration of their lumbar alignment, is able to go back to their activities, and is really happy with this. Here is another example. This is an 18-year-old with severe lumbar curve, and she's a very high-level swimmer. She was really interested in doing this in college and do this in a very high level. And again, I decided to correct the lumbar spine, and she's able to return back to her full sport and able to compete at a collegiate level, at a high level, which is pretty cool. Here's an example of a younger patient. Now, this patient is one of the few examples where we can actually do scoliosis surgery without having to fuse the spine. So in other words, instead of putting screws and rods that stay forever and limit motion to some degree, we can actually do a surgery where motion is not limited whatsoever, because instead of a rod, we still put the screws in, we put a flexible rope. And that's what I did for this child. So this child actually had a flexible rope inserted. It's known as a vertebral body tether. Now, not everybody's a candidate, but select few patients are. You kind of have to find the patient at the right age, right amount of growth remaining to enable this kind of operation. And I was very happy with our outcomes. And this child has their full flexibility, is very happy, and is doing well. So in conclusion, scoliosis surgery has come a long way. We are really proud to have a fantastic team that collaborates on taking care of these patients. We are able to do several hundred of these a year with very good quality, very good success, and very happy patients. And what really enables this is enhanced recovery pathways with dedicated teams, as well as leveraging technologies that allow us to fuse less levels, and in select cases, do what's called vertebral body tethering, which is a fusionless scoliosis operation. So that's pretty cool. Thank you very much.